John Talaga.
Thank you very much, Steve. First of all, I apologize to everyone for some of the technical difficulties we had there. It allowed some of you others to join, which maybe it benefited that way. We will still get through on time. And Steve, again, thank you for the introduction. And we are very proud to be part of the Dallas-Fort Worth Hospital Council as associate members, and look forward to sharing some information today. Just click on to go to the next screen. As Steve mentioned, just very, very briefly about Flywire Health. So you're seeing some of the name of OnPlan. So we're giving you a little bit of a preview here because we are rebranding as Flywire Health starting March 1st. OnPlan became part of Flywire Health last January, a year ago. To combine and integrate our international and cross-border payment solutions with our domestic patient payment solutions. We serve over 1,700 partner institutions, and as Steve mentioned, we have our team has a long history of developing patient-friendly billing, in which we worked with the HFMA back in the early 2000s, and we also pioneered in 2015 first automated payment plan solution. And we'll talk a little bit about that today in terms of what that means. Back here. So our session focus today is, first of all, about empowering patients, driving revenue for the providers, talk about some new technology in terms of supporting that, and then ultimately improving the collection performance. And then we're going to hit on a case study for Catholic Health Initiatives in terms of what they did across all their different markets around the country. First thing, McKinsey did a study that I feel that is always interesting to look at, because there's a myth out there that healthcare is very different from other industries. And while there are certainly clear differences in terms of the services that are being provided, from a consumer perspective, McKinsey pointed out that there really aren't that many differences in terms of what the traits are that consumers value in companies. Things like providing great customer service and delivering on expectations, making life easier, offering great value. So whether it's a healthcare company or a provider, or even retail, or going to retail or some other service that you may provide, these are generally the things that consumers are looking for. The clear difference, especially on the revenue cycle side, that hospitals are facing is the affordability problem. So as many of you know, and I'm going to assume that most of the people on this webinar are well aware of the Affordable Care Act and what type of impacts that's had on the providers and the patients. But these are market shifts that have had dramatic impacts on both. One of them is the patient deductibles have gone up by 25% in just the last 5 years. That's led to the patient responsibility of the total charges being at 25%. And if you recall, not too long ago, and then maybe even some of your hospitals, that those patient responsibility was as low as 10%. So hospitals would send a bill, and they would maybe put a phone call into high balances, and they'd collect as much as they can, which typically was around 30%, and then they'd write the rest off or put it to bad debt collections. With that increase on the overall amount of the charges going up to 25%, that certainly is no longer sustainable for running a clean bottom line. If you look at the patient impacts, an unexpected $400 balance or bill is a struggle for almost 50% of the patients to pay. So there's patients that have a $400 balance, which may not seem like a lot when we're billing out for healthcare. Most of the patients just don't have the savings or the reserves to be able to afford that. And that's leading to essentially, with the high patient obligation, is the patient being considered the new payer. So the new payer as a patient is really meaning that we got to start figuring out how we collect, because 25% is as much as commercial or even Blue Cross Blue Shield in some cases, where how do we start collecting and treating patients much like have the same expectations of collecting from insurance companies. If we don't do that, I mean, I always use the example, can you imagine only collecting 30% from Blue Cross Blue Shield or only 30% from some other commercial insurance? it would be completely unacceptable. You're expecting to collect 100% or at least 95%. So it really should have those same expectations of the patient. So how do we do that? So we did a consumer survey just recently, January of this past month. Flywire did it in connection with payments.com. And we surveyed 2,837 respondents who had a medical service during the past year. And the goal of this survey was rather than just looking at it from the lens of the provider, looking at it more so from the consumer or the patient's perspective, and gaining a better understanding of how the patients are paying for and are what their expectations are for paying for medical services. So we can send that publication to you. It's a very, very comprehensive survey, which is very insightful. And in fact, it's been published at Health Leaders. Becker's is putting out a piece on that in the coming months, as well as HFMA. Just looking at this survey and the insights that came from that. But the key findings, just at a high level, is that 45%, almost 45% of the respondents have used payment plans to pay their balance. Now, while this may seem like either a high or low number to you, this is also with most of these payment plans being requested reactively by patients. So instead of offering them proactively, these are patients, almost 45%, that are using payment plans by having to go ask the hospital for them. The average balances for those that have payment plans versus non are not as wide as you might think. You might think, well, payment plans are for the high balance patients where they really owe a lot. But if you really look at it, for those that are using plans versus not, the balances really aren't that significantly different. So there's a lot of other factors that come into this, such as the ability to pay by the patient, the availability and ease of accessing plans from the hospital, and a number of other different factors. It isn't just high balances. Another big takeaway was the respondents when they would like payment plans offered. So they were presented with the question that if the hospital were to offer you plans, when would you want that plan offered? And what we found very surprising, or it's really validation, is that almost 57% prefer to have a plan offered to them either at the time of service or prior to service. And then 35.5% prefer to have a plan offered when they receive their very first bill. So both of those things, both pre-service as well as the time of service, is only about 10% or 15% of hospitals in the country right now are doing it. Most hospitals are still waiting for a patient to call and ask for a plan because that's just the technology and means that they have. And that 6.9% is a very low number in terms of how patients prefer getting offered a plan. Yet that's how most hospitals are approaching and engaging the patients. Another takeaway is payment plan fees. So we're seeing more and more in just overall consumerism is when a consumer has a high liability, whether it's car or insurance, that they have the ability to pay over time, and there's service fees that are attached to paying over time. This provides two things. It provides an incentive for patients to pay in full or choose shorter terms, or avoid having to do the plan altogether. We're seeing more and more hospitals that are now starting to leverage incentives like service fees to be able to impact the behavior of the patient in terms of how they're paying and how long they're taking to pay. And when we look at this question from the survey, 33% choose shorter terms to reduce their fees. So for those patients that have fees from hospitals or other industries, almost a third will choose shorter terms to reduce their fees, while 17% will pay their balances in full to avoid the fees altogether, meaning, well, I could afford to pay this, but I'll take a plan if they're going to give it to me. 17%, because of the fee, will choose to pay in full. 25% are avoiding plans due to fees altogether, and 25% say there's no impact whatsoever. They either need a plan or they don't, and the fee's not going to have an impact. So another key finding to consider. So when you look at these things with consumerism and you look at some of the findings of how patients are expecting or look to get paid, I love this quote by Albert Einstein, although it's questionable whether he really did the quote, is that doing the same thing over and over again and expecting different results is the definition of insanity. And it's time for hospitals to look at things differently and sort of change the mindset. We look at shifting the mindset from what's typically called billing patients to responsive. Let's talk about what responsive means. So instead of just processing bills and sending them out, there needs to be some account segmentation. So responsive means responding to the needs of the patient's ability to pay, as well as their current status of where they are in life. So meeting them at where they are instead of just sending them a bill. So using account segmentation allows hospitals to look at things like credits, how they've paid in the past, what their income is, what their employment status is, credit to debt ratio, various things to kind of put the patient in a profile individually to say, here is what this patient can and can't afford. And then what do you do with that? Instead of just sending a statement with the balance in full, it really turns into an offer. So being responsive means, now that I understand this about the patient, I'm going to present an offer to them that's both mutually acceptable to me as the provider, as well as the patient in terms of what they can afford. And then when it comes to payment plans, knowing that 50% and growing are going to have to use payment plans to pay off their balances, instead of just being reactive and setting up a payment plan traditionally, it's allowing the patients to see their offers and be able to do self-activation. So self-activation means the ability to go online, click the offer, put their card on file, access and manage their plan, or in even some cases, which we'll talk about, allowing that patient just to write a check or walk up to the window to make their payment. And then the last one is, while the patient responsibility is significantly growing, more and more hospitals are leveraging the resources of early outs and pre-collect vendors. And those services are extremely important now because hospitals can't afford, with the additional calls they have and the additional volume of payments, to be able to collect that all with just the staff they have. But instead of just placing accounts with early out at a certain day and time, whether that be day 1, day 30, day 60, it's really being selective about when those accounts and what accounts go to early out. So running them through the segmentation process, making offers and self-activating before the time that you would normally place these accounts with early out, and being selective with that is going to help drive down the amount of placements that are going to your early out vendor. What that does is it dramatically reduces your cost, as well as make sure that they're working on the hard accounts, the ones that really need follow-up to be collected, as opposed to just collecting the cream of the crop. So in quick summary on this is Flywire's strategic response to this is very much taking this whole responsive platform and putting it together into a workflow tool that hospitals can use. We call this payment support program because really that's what we're doing, right? We're allowing hospitals to give patients payment support, not just ask them for payment and send a bill and require them to pay by a certain date or send them to collections, but support them in terms of where they are and their needs, and do this through segmentation, engaging the patients with offers, self-activation, and then most importantly, in many cases, is managing and automating those account changes. So as we all know, in the provider setting, that once a payment plan is set up or a service is rendered and there's a bill that goes out, there's all kinds of noise, right? There could be pullbacks to insurance, there could be late charges, there could be new balances from follow-up visits, and being able to really simplify that process and manage those changes automatically becomes very important for the patient to not get confused, not have to call on the phone, and not get frustrated with the service. So let's look at a couple of these things and connect some of the dots from the survey as well. When you look at The pre-service payment. So in the survey, 57% of patients want a payment plan offered before or at the time of service. Doing so means that off the estimate, and you know, there has to be a good solid estimation, a platform that the hospitals are using to say, here's what we think that you're going to owe. And then taking this and being able to present segmented offers from the estimate. So if you owe an estimate of $1,000 is what we think you're gonna owe, being able to allow that patient then to set up a payment plan as an option or pay a in a portion of that bill, to be able to set that up at the very beginning off the estimate before service has been rendered. Particularly with maternity and certain elective some elective procedures, this even becomes more important because this is something that they're choosing to have as opposed to reacting through the ER or some other service like that. So it also allows them to activate plans based on the estimate. And also then, of course, what's really important is adjusting those plan terms when it becomes self-pay. So if that $1,000 balance is set up at $100 a month off the estimate, service is rendered, final bill takes place, becomes self-pay. They now, let's say instead of $1,000, the balance is $1,200. You need to be able to adjust off that and communicate out to that patient that their plan has changed, and what the new terms are for them to look at and accept. The other thing that's important here is many times when there's an estimate, the patient has other balances that they haven't yet paid. So the ability to pull together both an estimated balance for a new service and then an existing balance from a service they haven't paid, being able to pull those together and actually set up a plan off the estimate, but also at the same time collect an outstanding balance. So those are several things that really kind of go towards solving this 57% of patients that want to be offered terms or options at the time of service. Another part of the survey that came out was that 36% of patients want a payment plan offered when they receive their first bill. So there's going to be some other patients that say, okay, I got the estimate, I'm waiting for my insurance to pay. And that's one of the reasons that not everyone pays at point of service or pre-service today anyway. So there's this 36% that would prefer on their first bill. So your insurance is paid, and being able to show that very clearly on the statement itself, that here's your account summary, here's what you owe, your insurance is paid X, and here's your balance. But then including a consolidation of those different services that they've had. So one of the things that's really important in terms of go back to that consumerism slide of making things simple. One of the most complex things in healthcare is having to send multiple bills out because the system happens to bill out on an account basis. So there's ways that even though the system natively sends them that way, you can bring these together to make the patient experience be able to see all their accounts in one place, and still being able, like in this example, it would be an example of sending two statements here, but instead of send one statement with an account summary and bringing those two visits together on the statement itself. Once you've done that, now you're in a position where you can give the patient an offer, right? So now we're from that segmentation, this patient's qualified, we're now giving them an offer on their statement based on what they owe. And in this example of a $3,000 balance, they have the option to either pay $2,850. You can extend a prompt pay discount if you want in this example of CHI, or you can offer them the ability to pay over time, 12 months. So this offer is what drives the patient then to have a couple options. They can go online to be able to activate that plan, either mobile or through their desktop, or they can even write a check. So the ability to offer self-activation, now we're on the self-activation pillar, is the ability to go online and do it, or even if I write a check of the offer amount of $253.95, having the ability for the hospital to receive that amount and then have them activate my plan automatically because I choose to write a check. In healthcare, we find that still almost 50% of patients are still writing paper checks as opposed to paying online, while online is still the greatest increase in growth of where the payments are going, there's still a large amount that are still writing checks. So being able to serve them in the self-service, self-activation way remains important and still in 2019. So on that point, as you saw, the paper statement is that really kind of turns into that engagement piece for the patient, understand what they owe. But there still has to be a large drive to digital payment and self-service. And this means allowing all options. And if you look at this graph from 2015 to 2019, you can see both on the medical side, the ambulatory side, as well as the acute hospital side, there's a dramatic growth in terms of digital. So yes, eventually we're going to get rid of paper, but healthcare is probably one of the slowest adoptions of that because of the nature of the service. I don't go to the hospital. I hope I don't have to go back there. So there may not be a login, and then there's still going to be paper. But there is a significant and sustained growth within digital, which is both mobile, online, e-checks, the ability to pay without logging in. So you have to allow patients, you don't require a login, but they can just pay online. Allows them to put their credit card on file, self-service payment plan activation, as we mentioned, managing their entire accounts and being able to access history of payments as well as notifications on their online account management, and including intelligent notifications, whether that be through text or email or otherwise, and then providing some the same conveniences offline as well. One other thing I'll mention here that's really important is for some Cerner Epic users that may have their EHR in which they're driving patients to, and they're going to want the payment experience to live inside there, there has to be single sign-on as well. So you're still driving patients to the EHR for the clinical reasons, but then being able to offer all these services and engagement on the payment side within the patient portal. So this is kind of an example of some of those things on the digital side. While there's still a bill, so this is just a quick example of the paper statements or an email that if a patient doesn't qualify based on the provider rules for a payment plan offer, because it doesn't mean you have to give a payment plan offer to everyone. This patient owes $80, so they're going to get a bill asking them to just pay their $80. But you can. This is also going to go out on email, which obviously is one of those things that patients are going to typically use as their username for sign-in. But then they can opt in for text as well. So in the TCPA rules that the patient has to opt in, whether that be at the front end with patient registration, where they're allowing you to use their mobile number to send them reminders as well as a balance that they owe. If you don't do it there, then having your web services when a patient logs in to allow them to accept and authorize to send it via text if that's their choice. But offering email, paper, as well as text is critical. And then another one is chat, being able to allow that patient, if they have questions, to not have to call, but being able to use chat to be able to get those questions answered. There's also chat bot out there as well, where it's robotics that allows patients to be able to ask questions even after hours, in which the chat bot will answer the patient with, give them those general answers. And if anything falls outside the chat bot's ability to answer it, it would put them to either a secure message to be answered by the call center reps or a follow-up phone call. So those are really the, kind of the key multimodal engagement ways of managing the patient payments. The other that I wanted to point out here again is the online offers and activation. So if you look at this example of the online, this is an example of a patient that's qualified for a plan for 12 months and for 18 months. And this is where you can really see the incentive of a service fee having an impact on the patient. While this balance is high and this patient more than likely can't pay this in full, this is giving them an option for 18 and 12 months, and it gives them the $395 service fee, which is included in each installment payment. So when a patient looks at this, if they're on the plan for 18 months versus 12 months, their fees, it's going to cost them more. So there's some skin in the game for the patients to give them incentive to choose shorter terms or pay in full. And that again goes along with the survey results, which we showed 33% of patients are paying in full to avoid fees, and others that are choosing shorter terms, or they just don't have an impact at all. Okay. Another thing that we would be remiss if we did not include this in a discussion with increased payments is, as patient responsibility goes up, that's going to result in more credit card and online payments. So naturally, in doing so, it's really important to know as we travel around the country, we see many hospitals that believe that as long as they're using a vendor web service for entering credit cards from patients that they take a phone call in, either in person or over the phone, that they are okay entering the card information because it's on a vendor web service. While that may be okay in terms of the vendor being PCI compliant, it still adds scope for PCI compliance to the hospital. And what that means is there's a solution to that in terms of focusing on now not transmitting any of that card information across your network by using point-to-point encryption. So point-to-point encryption ensures that any of the reps that are either in person or over the phone that are collecting or capturing card information are forced to enter it on the device, which has encryption keys to it, which ensure that it's an encryption that's trading a token with the merchant processor, and then no card information will transmit across the network. So Treasury will love you for that, because if Treasury is not on the call, because that's going to dramatically lower the scope and reduce the risk of any card theft while you're processing those cards. It's okay for patients because they're online and they're not in your network, unless you're an Epic user where they're using MyChart and they are on your network, which is a different approach. But generally, when they're not on your network using a web service from a vendor, it's on the PC with the patient, not the hospital. Okay. All right. One other thing that I think is important to mention is, with all of this, we have more information and technology available to track metrics. And in the past, and it's amazing how many hospitals we work with, not surprising, but amazing, that they don't know how many payment plans they have set up with patients, or what the average term is, or what their default rates, or what's the collection rate. It's just because of the way the system's been managed in the past and the way it's been set up. But now we have the ability to provide complete transparency into a self-pay financial reporting tool to be able to track the KPIs. And those are those default rates, and how many have canceled and completed, how many offers are there versus patients taking action, how many have paid in full versus auto pay versus mobile, et cetera. So being able to track all these is ultimately what allows you to get at how effective it is, and what you're doing, and what you effectively need to tweak in the system to get better performance. But what we see specifically within clients that we've worked with is that those KPIs that they should be going for is you have the ability to get 70% self-activation. There's going to be those 30% that still will make a phone call because they have questions on their bill that ultimately end up on a payment plan. Or it goes through a phone call that is outreach from one of your early out vendors. But ultimately, with the offer through segmentation, if you're doing the job right, that 70% will self-activate those plans. And nobody, almost 0% do it today. Reduction in billing related phone calls, that's going to result in less phone calls because patients don't have to call to activate a plan. We're seeing anywhere from 35 to 45% reduction in those billing related phone calls. And the other thing is a significant reduction in early out placements. And again, those early out placements can be with a day 60 vendor or a day 1 vendor. There's ways to set it up to ensure that only, again, back to selective routing, is only sending those accounts to early out vendors for patients that haven't self-activated their payment plan. So that's a big reduction in cost. And then at the very end of this, how you're going to measure yourself is how much more patient cash is coming in. And through this, the goal here should be 15%. I think there's certainly ability to go beyond that. but 15% is a reasonable goal in terms of increasing that patient cash based on this this process. Okay, so we have about 10 minutes left here before we're going to take some questions. And what I wanted to do is just run through kind of a rapid case study. We actually were at the HIMSS conference this past week, and with CHI, we presented this brief case study. And just a couple of quick things on CHI. While they're a huge national organization in terms of their corporation, they're really 100 different hospitals, right? And most of their hospitals are, most of their hospitals are small to mid-sized hospitals, and they have some large epic academic medical centers as well. But when you look at it, they have 12 separate markets that are divided up into individual hospitals that have Meditech, Star, Epic, and Cerner. So a very complex system with their different EHR systems. And they went live with Flywire Health in March of 2018. And the previous state, which kind of led them to looking to do something, is that they had everything that was managed through their third-party extended business office. So they still have an early out vendor that manages all of their, all of their self-pay, and they had a lack of control at some point over the patient statement formats, content, and really just the overall experience. What they wanted to do is look at taking this back because they had a highly fragmented online payment capability. They had payment plans that were set up completely manually over the phone when patient asked. They had limited transparency on the performance metrics overall, so they didn't really know how well they were doing or where they could improve. They had difficulty managing balance adjustments, pullbacks, late charges. Those things were very, very manual, which often resulted in large delays in sending statements out or rebills. And then in the end, it was the opportunity to improve collections on patient responsibility. So they knew that they had some financial challenges that they wanted to increase that self-pay as it continued to increase overall. So here is what their objectives were. So they wanted to improve the financial experience, and through a couple of things, they knew they needed to improve their statement design and delivery. They wanted to standardize that across all their hospitals so that if you're a hospital in Texas, CHI, or a hospital in Minnesota, you're going to have a very similar experience, same look and feel. And then provide options to engage and pay. So before it was just send a bill, here's your total balance you owe. Offer automated payment support, which we mentioned before. So go through the segmentation process, offer self-activation, and then of course drive mobile and online access and payment. They had very limited online. Almost every hospital had a different service offering, and a lot of those systems are outdated, and they really just didn't have a lot of buying power on that. So, and they also want to improve their operations. So so they looked at this in two ways. Let's improve the patient experience, but also let's improve our operations. So if we focus on the patient first, it's going to trickle down to our improvement. And that was to integrate their strategic workflow partners. They have partners from both estimation as well as financial screening, as well as their early out, and be able to bring those all together. They want to develop a new engagement model completely, so that they had the ability to connect with patients differently other than just a bill and waiting for them to call. Automate their payment plan management, increase transparency into their overall reporting, and then ultimately manage their risk and scope for PCI compliance as well. So very much, this is I'm going to go through this fairly quickly, but this was their process automation that was put together with them across the board. So each day a file comes into Flywire in which the segmentation of those accounts based on history, ability to pay are being done. Ultimately, CHI puts together their guidelines in terms of who should qualify and who should not qualify for a payment plan. Because remember, this is a mutual agreement between the patient and the provider. So we're going to make offers to you that you can self-activate, but these are going to be offers that we're willing to fund for you over a period of time. So those qualifications would come into based on the balance as well as the patient's ability to pay, in which that patient would ultimately either get a pay in full statement, you owe $80, or a payment plan offer, which would say you owe $1,000, but you can pay us $250 a month. In doing all that, it was going to the patients via paper, text, email, and then allowing online account management as well. So the communication to the patient based on all this information was connected through Flywire. And then also anytime there's a new balance and a patient had activated a plan, those are automatically being added to their existing plan. So I have a plan for $1,000. I'm paying $100 a month. I have a new balance that came in for $500. My new balance is $1,500. What is my new offer? And being able to allow that patient to click and accept an offer by adding that new balance. If they're already on a payment plan, chances are that they have new balance, they're going to still need to be on that payment plan. So knowing that up front and making it simple on the patient is critical. The other critical thing for CHI is making sure that every one of their 4 different EHRs and host systems are kept up to date. So any of this activity that's going on with the patients are being sent back to the host system to make sure that that system of record remains the system of record and that the workflow and work queues can continue as normal. So in an Epic environment, it's billing indicators that are sent up whenever there's information that's exchanged. In Meditech, it's sending an agency code change so that it doesn't cycle out to bad debt when they're on a plan. And then with Star and Cerner, there's agencies and other indicators as well. But in other words, making it work in its native form. And then whenever a CSR takes a phone call, being able to go into the system, regardless of what system or what market they're on, being able to have a consistent experience, to be able to see what the patient's seeing and be able to activate those plans and capturing cards with a point-to-point encryption device so they don't transmit anything across their network. And then lastly, making sure the payment posting process is, the payment processing is PCI compliant, but the payment posting is critical. If you're consolidating accounts together in a patient accounting environment, it's important then to be able to have the lockbox use an OCR line, but still have the ability to post from that lockbox to the individual account level. So that becomes real important. Otherwise, consolidated statements become very cumbersome if you don't solve the payment posting process. So CHI put this together and resulted in what we had showed you. It probably looks familiar because we showed this earlier in terms of the statement that's going out to the patient on a consolidated format, consistent across systems. And then also the online offers and activation, whether it be on their mobile device, tablets, or on their desktop. They instituted the service fees, which have been dramatic change in terms of what it's done for the payment plan activations as well as default rates, allowing them to put cards on file, pay without enrolling, et cetera. So a lot of those things that they want to achieve were accomplished and standardized across all 100 of their hospitals. So the results. So these results are ramping significantly. Again, going live in March, they're still actually rolling out hospitals because they have 100 of them, and it's going by market. In fact, their Texas market will be launching in a month and a half. But as this ramps and it continues to improve, they're at a 70% patient-activated payment plan rate. So only 30% of their payment plans are now being set up by phone calls. Used to be all of them were phone calls. They're now controlling the improved statement and online experience across all the markets, so it's standardized, and they're in control of it, so they can make changes when they want. They can ensure that the host system remains true as the system of record. They're significantly increasing their self-pay cash collected. They'll be sharing, we're actually doing a presentation with them at HFMA in June. They're going to be sharing more numbers because this is still ramping, but they're seeing a significant increase. And then average payment plan term is down to 12 months, where it was in the 26-month range. And that's just a matter of, instead of leaving it to a rep to negotiate a plan, which usually the patient wins because they're going to tell you what they're willing to pay. It's now putting these offers with time constraints in front of the patient for them to be able to activate plans that are reasonable for the provider to fund. So that's down to 12 months on average now. And then the payment plan default rate is down considerably as well. So they did have challenges with defaults, as many hospitals do, simply because there's a lack of follow-up. But in this case, what they're doing is they're sending text reminders when there's a missed payment. They're creating discipline to have the patient not only pay their current month that's past due, the month that's past due, but the installment also that's current. So they have to pay 2 installments to catch up. So by driving this more disciplined way, it reduces the defaults. And the segmentation just makes sure we're getting the terms right. So instead of just negotiating something, you're getting it to a point where you know the patient can afford a certain amount over a certain period of time. So you're not asking them anything that they're going to end up not being able to finalize their payment on. Little tongue tied there on that one. Dramatic increase in online payments too. So they used to have probably about 15% of their payments that were online at their best hospitals. Some hospitals didn't have online payments, and they've now increased that where almost 50% of their payments across the board are coming online. They have greatly improved metrics visibility, a very key thing that they needed. They needed to know, and they get a scorecard each month. Actually, they look at it each month. They can download it at any time, which gives them all the information, the metrics that they're tracking for tweaking it and seeing how they can improve. And then the last part of it is enhancing the patient experience and transparency. So there's been a lot of satisfaction not only by the patients but their markets in terms of being able to finally have control over how the experience is with their patients, and they've gotten tremendous feedback from their patients as well. So with that, I think I ended right almost giving 10 minutes for questions. So Steve, on your side, if you wanted to, I'm not sure if you've got any questions. I'll wait for those.
Yeah, we do have one question here, John. This is pretty good one. Would you be able to work with my current early out vendor, and if so, how?
Yeah, so good question, and just kind of expand on that from what we had just talked about. In all cases, from a Flywire perspective, we work with whatever early out vendor that the hospital is currently using. So we don't come in with the solution to say, hey, you're going to change your early out vendor because we're integrated with this one. Our integrations all go to the host system. So that makes it natural to use the native connections that the hospital already has with the early out vendor. So we're really going through billing indicators and agency codes that are then triggering the communication out of the host system to the early out vendor. So the answer is yes, it can be any early out vendor that you're currently using to do that integration.
We have another one here. It looks like if we implemented this solution, how would existing payment plans be handled?
Great question. So I did not cover that at all. So when you put a new system in like this, you don't want to, of course, leave the old plans the way they are, right? And now you've got this group of patients that oftentimes are going to have new services, and you don't want to have two experiences. So the way Flywire handles that is we will consume a file at implementation of all the existing plans out of the system. So that file will then are basically set up and activated plans in the new system so that they're treated exactly like any other plan that a patient activated. The only difference is that since the plan's already been accepted and active without a service fee, then if the service fee is in place, that's grandfathered. So they only get a service fee on a new plan as opposed to a pre-existing plan.
Okay, we have another one here. Have you had any success working with ancillary services or all of your client hospitals?
So just to restate the question, so if we had any success working with other ancillary services with our hospitals, is that right?
Yes, that's correct.
So yeah, so one of the things that
I think what they're asking is all of your clients' hospitals.
Oh yeah, got it. Yeah, I understand that. So no, our focus from a Flywire perspective right now is health systems that have either owned or affiliated physician groups and ancillary services. So we're not currently just selling to physician groups. However, we do have a group, a partner group within our company that is now focused on that group through partnerships. But right now, our focus is health systems that have hospitals that are either affiliated or owned with by the same system for physician practices and ambulatory.
Here's another one. How do you work with a financing vendor?
So a couple of different ways. So that's a little more detailed conversation, but at a high level, one of the things that our system does, which a lot of our customers have actually turned off the financing vendor because they've gotten so efficient at managing plans that they're willing to fund. But what it also enables them to do is to use the financing vendor strategically. So that means that with the segmentation, you can identify that this patient will get an offer for what the hospital is willing to afford or fund. Let's say it's 12 months, or it can then be pushed to the financing vendor as another option if it exceeds the amount the hospital is willing to fund. So that's one way that we do it. And then we also allow the plan to continue to live in the system. So whether it's financed or not on the back end is between the financing vendor and the hospital. The patient doesn't have to come into the middle of that, which makes it a seamless experience. So a little more detailed conversation, but that's the high level answer.
Okay, so it looks like here Eric has added to his question that he had earlier, if all of your clients are hospitals. For instance, do you work with anesthesia or radiology?
Yes, so great question. And that is a focus that I mentioned that we have a group that's turned to, is we are experimenting and starting to work with anesthesia groups as well as dental and orthopedics that are separate from the health system. Clearly that those are groups that have high liability and have a need for our services. So we've had a lot of demand for that, and we are opening up to the services for that as well.
Okay, we got another question here from Ty. He's asking, how about the $3.95? How are facilities and patients receiving that fee?
How are they receiving it in terms of financially, or in terms of reacting to it? Do you know? If you probably don't know either, right?
Well, I'm not sure. I'm looking at it here.
Let me
reacting.
Yeah, reacting.
Reacting.
Got it. Let me answer both. Well, answer the reacting. So it's the service fee is something that's new in healthcare, and it's certainly all of our clients we give the option, right? The option is you can extend the service fee as part of the installment for your patients. The benefit that you get is the incentive for them to pay in full or choose shorter terms. It also pays for the service, so it's a very inexpensive way to go because the patients with their incentives are funding it. But they have the option certainly to pay for it themselves if they don't want to offer their patients. They don't want to include the service fee to their patients. 100% of our clients have the service fee charged to the patient. And what we always do is we go on the back end to say, if it doesn't work out, or if you feel that there's a lot of complaints, which we don't expect, then you can revert back to the paid model. And none of our hospitals have had to do that. I think what the hospitals find is that there's low barriers to that with the consumers. There's probably more worry on the provider side because they've never done it versus consumers that are used to it. And there's very little pushback. And oftentimes, even though you can waive a fee if there's a certain circumstance, less than 0.5% of those fees are waived. So it's been received very smoothly, and there's very, very few questions or even complaints.
We have another question here. Can multiple accounts and facilities be combined into a single bill and payment plan?
Yes. So that's a key thing for the consolidation. So bringing together multiple facilities. Well, first of all, do the consolidation within a single hospital. You kind of look at the hierarchy, meaning that let's bring accounts that may have separate bills together on one statement, and then being able to bring separate facilities together on one statement. The only key requirement there is that there's a unique identifier. And with the EHRs now that health systems are affiliating with multiple facilities, oftentimes there is a patient identifier that allows us to leverage that for the statement as well, and send one statement out, simplify it for the patient, and then allow them to be on one payment plan as well.
Well, I think that's all of the questions.
Great questions. Thank you, everyone, for presenting those.
Thank you, John. That was an excellent presentation. I wanted to let all the attendees know that we're going to send out a copy of John's presentation to you here today. In addition to that, this webinar has been recorded, and we will post that to the Dallas-Fort Worth Hospital Council YouTube channel, and I'll send out a link to that to all the attendees as well. John, thank you very much. That was a great presentation.
Oh, thank you very much. Everyone have a great day, and I appreciate you having us.
Thank you.